folks for joining us. This is Lunch with Docs HD, and it is through Parkinson and Movement Disorder Alliance. We are glad that you've joined us today. This will also be recorded, and so that we will have it up on our YouTube channel a little bit later. Brought to us also with HD Support and Care Network with Melissa Bellardi. She's not with us right now, but she might be joining us a little bit later. She had an emergency she had to attend to. But we have with us today Dr. Paarth Shah. And Dr. Shah is a movement disorder specialist in the East Valley of Phoenix metropolitan area. He is an Arizona native, and he received his medical training in New York and California. Plus, he did his movement disorder fellowship with Barrow Neurological Institute with Dr. Abe Lieberman. Currently, he is in Gilbert Neurology Group, and he is dedicated to providing excellent HD care to our local community. Dr. Shah, we are privileged to have you with us. We're grateful you have joined us. We know that you have a busy schedule, and so we don't take that lightly. We are just grateful that you are with us. So I'm going to turn it over to you, and you can talk to us about the trifecta of symptoms affecting HD.
Yes. Hi, Margie, and everyone else that joined us. Thank you for that warm introduction. It's a pleasure and privilege to be speaking with you all. I actually enjoy these sort of community events very much. It actually keeps the it's the more fun portion of my job, so to speak, in many ways. Sorry for being late. Clinic ran a bit behind than I anticipated. But so anyways, today I wanted to discuss Huntington's disease and the bread and butter of HD, which is most Huntington's disease specialists who are movement trained neurologists, we all view Huntington's as a trifecta. And that's for good reason, because Huntington's really affects three major domains for the human body. It affects the psychiatric components, it affects the motor, which is the physical components, and it affects cognitive, which is memory and thinking. So even though psychiatric is labeled first, I'm actually going to start with the motor symptoms first, because motor tends to be the biggest component, is the one that's recognized more prevalently and tends to be the first symptom that patients notice. So among the motor symptoms, the most classic and famous is what's called the Huntington's choreiform movements. So chorea is a subtype of a movement disorder. They are wide body, moderate amplitude, writhing movements. And then so these are like these snake-like dancing movements that tend to start in one body part and extend to the other. It can affect the arms, the legs, the chest, upper torso, the face, the head, everything. These movements are classic for Huntington's, though they are shared in common with several like other disease processes. But every time I see a patient comes in with choreiform movements, the first thing I think about is Huntington's. So that's the biggest, or that's the most common and most famous component of the Huntington's physical manifestation, is the choreiform movement. In addition to the choreiform movement, patients have some Parkinson like features, such as they get slower, stiffer, have rigidity. They don't tend to develop the tremors that we see in Parkinson's, but they have some of the other motor symptoms of Parkinson's. They get problems walking, they have balance issues, they fall down, they drop objects from their hands, they have loss of dexterity and fine motor control of their hands and feet. Their speech slurs, they get dysarthric, they have difficulty chewing and swallowing. These are all manifestations, the physical manifestations of Parkinson's disease, what we characterize as the motor symptoms. Every patient has a different constellation of motor symptoms. Some patients' motor symptoms are very severe, some patients are very mild, some people have very severe choreiform movements, but the other motor symptoms are mild. Some people have vice versa. They don't have a lot of chorea, but they got a lot of the other things. So everyone's HD is different in his own way. But these are just the combination of physical traits that we see when we examine a Huntington's patient. So that's the motor component. That's what typically is seen first. Patients will come in, usually their spouse or a family member will say they've had these choreiform movements or they have problems walking, so on and so forth, and then we examine them, they have the rest of the physical symptoms. Now, let's talk about psychiatric. So psychiatrically, Huntington's patients do sometimes develop psychiatric problems. Not all of them, but many of them do. They tend to have personality changes, short temperament, angry, frustrated. They can have hallucinations, psychosis, paranoias about different things. And it's a combination of those. So, for example, someone may say, hey, you know, when this patient was in their early 20s, they had some personality changes that developed slowly over time. They thought everyone was out to get them. They were very paranoid about things, so on and so forth. As those symptoms typically progress on, then you tend to have the full-blown hallucinations and psychosis, which tends to occur a little bit later on in the Huntington's course. So that's the psychiatric. Cognitive really is just memory impairment. So these patients have developing dementia-like traits. So they have short-term memory loss, long-term memory loss, poor judgment, poor executive functioning, where they don't think and can't correspond appropriately. They can't multitask anymore. They have a hard time concentrating on things. A lot of times what I see is I'll have a young patient come in, hasn't been fully diagnosed yet, is still working, but they notice, they're like, hey, doctor, I've noticed that in the last 1 to 2 years, I just can't multitask anymore. I used to be really good at multitasking. I used to have really good concentration, but in the last 1 to 2 years, I just can't concentrate anymore. My multitasking has gone down. My work performance is declining. That's a red flag. And that story is very common in my Huntington's patients. So to recap, we talked about the motor symptoms, the choreiform movements, the problems walking, balance, Parkinsonian type features, problems with chewing and swallowing, so on and so forth. So those are the motor symptoms. Psychiatrically, we have hallucinations, we have delusions, paranoias, temperament issues, personality changes. So those are the psychiatric issues. And then cognitively, we have memory impairment, problems with judgment, concentration, thinking. So these are a wide variety of different symptoms that patients develop. And typically what you see is you have a combination from each of the three domains. So for example, a patient can present with just very mild choreiform movements. They can have some personality changes and at the same time some concentration difficulties. Then I might see another patient who has, let's say, no choreiform movements, has a lot of balance issues, has a lot of psychosis, and has a lot of short-term memory loss. And then I might see another patient and a patient after that, and so on and so forth, that all have different combinations of these sort of symptoms. So it's very important to realize that Huntington's is even though the trifecta of symptoms is the same, the combination of different symptoms that a patient presents with and will develop along the course of his or her life can be very variable. And it's important to be seen by a physician who can recognize the trifecta and can recognize each of the individual symptoms in each of those domains and treat them accordingly, because the psychiatric symptoms deserve different treatment, the motor symptoms need different treatment, and the cognitive symptoms deserve different treatments. And so typically these patients need to be on a combination of different medications and therapy and treatments in order to address all of the different issues. So that's that's typically, that in a nutshell is what the trifecta of symptoms that affect HD are: psychiatric, motor/physical, and cognitive. Do we have any questions?
Okay, Rick, if you want to unmute yourself, I know you had some questions. Feel free to ask them of Dr. Shah.
I think I'm good now.
You think he explained it?
Yeah.
Okay. Dr. Shah, what would be a typical age for some of these things to begin to present themselves where a person might be concerned that there's something going on?
Okay, that is a very good question. Unfortunately, it doesn't have a very straightforward answer. As you may know, Huntington's is an inherited condition, autosomal dominant. The Huntington gene, Huntington, that's the name of the gene, is on chromosome 4. It has a CAG repeat. So normal repeats are typically less than about 29. Anything above 31 goes in the variable penetrance, and anything above 39 is considered definite, positively showing HD. So the number of repeats a person has dictates at what age their symptoms present. So juvenile HD patients who present in their teenage years will have very high repeats. Patients who present in their later life years tend to have lower amount of repeats. That's not a hard and fast rule, but that tends to be the trend. If we're going to take an average repeat patient, let's say in the mid-40s to 50s repeats, what typically happens is in their maybe late 30s or 40s, there are some concerns. And it's basically the thing that patients recognize the most is the physical symptoms, obviously, but it's also the cognitive, the concentration and the thinking and things becomes declined. So they present to me, and we examine them, and we are suspicious for HD, so we do the genetic test, and it comes back positive. In a lot of these patients, if I ask them, or their spouse, or people they've been with or dated for decades, for example, they'll tell us that, you know, when this person was 20-something, there was just something a little off about them, you know. Maybe just every now and then they would have a temperamental flip, or they would just get really upset about something that shouldn't hold a significant emphasis to the other common person. So there tends to be small little personality caveats that tends to predate the manifestation of the other symptoms. And that's usually a pattern that I've seen commonly.
So then a lot of times it's looking back at things after the diagnosis, but those things could have been coming up for years and they were aware of it.
Correct.
Are there a lot of instances where some of these symptoms might be brought to the primary care physician's attention, but misdiagnosed or treated for some other reason?
Definitely. I mean, for example, when I was in residency, we had a multidisciplinary HD clinic where we had a patient who was in her 50s that coming in for HD. She had a younger daughter who was in her mid-20s who tested positive for the gene, unfortunately. And she just kind of wanted to get a routine evaluation to see where she's at. Now, we all knew that she's going to develop the symptoms at some point. And she didn't really have any symptoms right now on exam or based on her history. But when you're talking to her, you can tell something's a little off. You know, her concentration's not where you'd expect it to be. She gets a little anxious or a little flustered about small things. And something that our boyfriend even mentioned too, be like, hey, you know, I've dated her, I'm really close to her, but, you know, she just gets really upset about some small things and stuff. And when you look at back, those are signs that obviously if there's no family history, there's nothing else to go by, it's going to be impossible for a primary care doctor to just think that, you know, small angry outburst at the age of 25 is an indication that this person is going to get Huntington. So But there are symptoms that occur decades earlier that obviously get misdiagnosed or misrepresented as something else, and later on in life we find out that these were actually initial presentations.
What would be a typical, or maybe there isn't a typical, but if there is, what would be a typical, what shall I say, roadmap for someone who has now been diagnosed with Huntington's for the either accentuation of those symptoms or progression of the disease?
It's hard to label a roadmap because every person is so different. I would say that typically it tends to be a worsening of the motor symptoms along with the cognitive, and then at some point the psychiatric hallucinations and things tend to start to click. And obviously there's exceptions to the rule. Some people just have hallucinations, psychosis early on, some don't, some never develop it. But that tends to be a pattern that we see in practice.
Are there steps that families or caregivers can implement to assist not just the person with the Huntington's, but themselves and those around them to assist in dealing with this and assist in their quality of life?
Well, family support is important, but at the same time, this is a difficult disease to deal with. And so I think once a diagnosis is made, I think family members and caregivers must start to think about what is going to happen when the patient's assistance gets to a level where they are dependent on others. And so I think it's a discussion and planning ahead of time that needs to occur.
Who would be those major players that should become involved in this process early on?
I would say it should be the individuals who play the primary caregiver role, which could be spouse, siblings, or children, or parents. And typically there should be a social worker that's involved. And then it's the physician plays the ancillary kind of role for guidance and counseling and things.
How often would you as a movement disorder specialist want to see your person with Huntington's?
It depends. If they're stable, I can see them, infrequently every 3 to 6 months. If they are not stable and there's a lot of changes that we're doing, I have to come back every few weeks.
Oh, okay.
It just varies.
Okay. Is there anything else that you've come up with, Rick, that you want to ask?
The only thing I can think of is, why does the gene, or how does the gene skip from one generation to another? In other words, from one sibling to another.
So it'll skip siblings, but it won't skip like generations, though.
Well, it skipped. My sister-in-law passed away a few years ago from Huntington.
Okay.
And my wife does not have any of the signs or symptoms, but her niece, who is the daughter of her sister, died of Huntington's.
Okay, yeah. So what happens is, for example, let's say you have a so if, let's say, the carrier is the father. So if there's several siblings, each of them have a 50% chance of having the gene from the father. So if they have the gene from the father, they're going to develop Huntington's, because Huntington's is an autosomal dominant, which means that that it is a dominant gene compared to the normal gene. So what likely happened is you say this was your wife and her sister?
Yeah.
Rick?
Yeah.
Okay. So your mother-in-law, did your mother-in-law have it or your father-in-law had it?
Father-in-law.
Father-in-law. Okay. So what happened was your father-in-law had the gene. Your sister-in-law got the gene from the father, but your wife got the gene from her mother. So your wife was saved. And then when your sister-in-law married and had kids, she passed the gene on to her daughter. If she has other children, for example, I'm not sure if she does or not, they also have 50%.
She's got one other. He's got the tendencies for Huntington.
Okay, so it's possible that he may have also had the gene.
He doesn't have full-blown Huntington's yet.
Okay, so he may unfortunately develop that later on. If he was genetically tested, we would know whether he has the gene or not. So your sister-in-law then, with as many kids as she has, she would always there will always be a 50% chance of each of those children having the genes. So that's why it tends to skip siblings. And it's a 50% chance that an offspring will have the gene. And when the gene is passed from the father, there's a higher chance of what's caused the amplification. Amplification means that the repeat number increases. And the reason for that is sperm have a higher tendency to mutate than eggs do. And so if it's inherited from the father's line, it's a much higher chance that if the father, let's say, had 40 repeats, the offspring could have 50 repeats, so on and so forth. So with each generation, the amplification occurs more and more. So if you look at these juvenile patients who are kids and teenagers with Huntington's, if you look at their hereditary line, they probably come from a long descending line of HD patients. They must be the 6th, 7th, 8th generation to develop them.
That's what I'm seeing on
Yep.
I belong to a website or a group on Facebook from Huntington's Disease Society.
Right.
And every oh man, kids dying at 8, 9, 10 years old, 12, 14, 16 years old. That's too young for me.
You're right. Yeah. And unfortunately, that's where how the amplification occurs. So.
What's the youngest age that you've seen Huntington's diagnosed?
I've seen personally, I believe she was 17. Something like that.
How often do you see family members of parents with Huntington's request to have themselves tested? Is that common?
It's pretty common. Usually, it's about 50-50. The children do want to get tested at some point.
Are there any steps that they can take to delay that onset?
Not right now.
No.
There's no medications or therapies right now.
Okay.
Commercially available to delay onset.
Is there any research going on for Huntington's on either the delay of or on the treatment of?
There is. Both.
If someone wanted to enroll in one of those research studies, where would they go to find them?
That is a hard question. So they would have to speak to their movement disorder physician and see if there are ongoing trials in their area for that. So every academic center has different trials and research that's going on. So it just depends on where they're located, how far they're willing to travel, so on and so forth.
Okay. Are there any new medications or treatments on the horizon that you know of?
There was so Austedo was the newest dopamine depleter that came. But that came out, I think, in 2014 or so. Or sorry, no, sorry, I apologize. That came out in 2016, I believe. Which is so before the only medication FDA approved for stopping chorea was the tetrabenazine. So Austedo is a new kind of tetrabenazine, and so that's one that came out. There, I believe there is a drug in trials right now, but I don't know how far it has gone.
Okay. Well, this has been great information. Rick, if you've got any more questions,
I'm good. I'm good.
You're good? Okay.
I'm good right now.
I think that we can let Dr. Shah go back to his clinic. And again, I thank you so much for your time, Dr. Shah. We look forward to seeing more of you and having you join us for our Lunch with Docs program. But we thank you for your time. We thank you for your expertise and your care of our HD people.
You're welcome. My pleasure. Thank you for having me. Looking forward to having more sessions with you all.
You are so welcome. Good to see you all. Thank you.
Likewise.
And thank you
Take care.
for joining us. Bye-bye.